Okay, the last lecture in this series is medications that we can give for people with different types of behavioral health conditions. So, again, this is changing how the body uses neurotransmitters in the brain. So, in order to treat or to give medication and expect there to be a change, you have to know that this organic versus non-organic. So there's different theories about why people experience behavioral health conditions, and they can be situational versus low-level symptoms versus higher-level symptoms where the person has an alteration in normal functioning. So organic means you believe, the provider believes, we believe, that people who experience behavioral health conditions have an imbalance of neurotransmitters in their brain. And so the medications are meant to balance that out, balance that out so that they don't have the symptoms anymore. The symptoms are decreased. Different things can make organic conditions worse. Situations can make it worse for people with these underlying neurotransmitter imbalance. And then all of these diseases have a continuum of symptoms. So again, the person could not have any symptoms at all. A situation could bring the symptoms on, in which case, once the situation passes, they might be better. Depending on the severity, they might just need short-term treatment. All the way up to this imbalance or this problem interferes with normal functioning, in which case treatment is definitely necessary in order to help the person feel better. All the way to psychosis, where the person sort of breaks from normal reality and definitely needs more intensive treatment. So we are going to be talking about these conditions in terms of they're organic, related to a neurotransmitter imbalance, and these conditions are starting to interfere with the person's normal activity, and therefore it has become appropriate to give these people medication in order to help them. So the first condition we're going to talk about is anxiety, which people tend to talk about occasionally with insomnia because that is definitely a symptom of anxiety. So anxiety itself is feelings of apprehension, almost a physical symptom of danger where it's disproportionate to what the danger is. And what's happening is an increased activity in the limbic system. The limbic system is inside the central brain and is in charge of some of your emotional response, and particularly the reticular activating system is in charge of your sleep-wake cycle. So if this activity is constantly, upswing and on an upswing, always activated, then the person is kind of hyper arousal. They are always kind of thinking something bad is going to happen. It will translate into some physical symptoms as well, like increased heart rate, palpitations, jitteriness, sometimes chest pain, where people will think that their anxiety is actually a physical condition like a heart attack or something, and they'll have a lot of trouble getting to sleep. So really the best treatment for people with chronic anxiety is antidepressants and talk therapy. However, what we used to do and sometimes do for people with really bad symptoms is similar to what we've done before, is to quiet some of this electrical activity. We slow this down, then maybe they will be more relaxed. And so that's what the earlier treatments for anxiety were. And because anxiety affects sleep often, these two are mentioned together. So insomnia is either the inability to fall asleep or remain asleep. And it, like I said, is associated with anxiety. And the reason why insomnia can be bad is because of what's supposed to happen when you are asleep. So stage 4 sleep, which takes a while to get to, is restorative. So that's when tissue repair occurs. And stage 5, or REM, is sleep, is the dream sleep, and that's really important for memory. So that's why people always say, don't stay up all night to study, because you are interfering with your REM sleep, which is what helps you lay down memory. That's why it's important to study every day, and then when you go to sleep, you help solidify that memory. So a medication that's supposed to decrease the activity of the limbic system and the reticulated activated system, so to decrease anxiety, would be one of those Gaba receptor agonists, the ones that allow more chloride to get into the cell, decreasing electrical activity, causing drowsiness and sedation potentially, but getting rid of anxiety. And those are just like diazepam, the diazepines. In this case, it's lorazepam that we're talking about. It's going to be given PO or IV. Again, the issue is drowsiness and sedation. The IV effects are more severe and can cause some disorientation and forgetfulness, especially when the person is older. So sometimes in the hospital setting, a person who's elderly, who's having sundowning, is agitated, the treatment would be, oh, let's give them lorazepam, which is Ativan, or something to calm them down. But for the elderly, that could mean disorientation, forgetfulness, which could increase their falls risk. The other issue is that sometimes people give these medications as a way to try to avoid that room for a little while and get something else done. But you do have to monitor the respiratory rate more often, just like we said for diazepam, every 5 to 15 minutes because of the risk of respiratory depression. So it doesn't mean that you can ignore that patient. You actually need to pay more attention to that patient. The best treatment for issues in the hospital is to try to maintain the sleep-wake cycle. So if you make people sleep during the day, you're not going to help their confusion at night for sure. And then you'll see on there that there's risk of misuse and dependence. So it's not really the first line treatment for anxiety anymore. That's why it's really better to use antidepressants and talk therapy. People become dependent on these medications, and if you stop them, they'll go through withdrawal. Additionally, you will have more issues if the person already has underlying liver disease or impaired brain function. So it's not the first choice. This medication could also be used for sleep. There are some non-benzodiazepines that can treat insomnia that are not meant to treat anxiety necessarily. And zolpidem, which is Ambien, is our prototype medication. It's really only for short-term treatment of insomnia. You shouldn't become dependent on medications, or you can have something called rebound insomnia. So if you take this medication the same time all the time, when you stop taking it, you're going to have more severe insomnia. That's why people can become really dependent on these medicines. It's really supposed to be for short-term management, and you shouldn't take it every night. You should take one or half or skip a couple days. It's better to try to do good, what's called sleep hygiene, which is only using the bed for sleep, not being on your phone or have a bright light in your face prior to sleep. No caffeine or beverages before sleep. All the things that we don't do are really help facilitate sleep better than any type of medication. The other issue with Ambien or zolpidem, which has given it a black box warning, is that it can cause neuropsychiatric effects. So people can sleepwalk, they can eat in their sleep, they can drive or do weird things in their sleep. Somebody used these neuropsychiatric effects as a defense against murder of their spouse, that they woke up and accidentally killed them, but it wasn't really them, it was the medication effects. So you do have to be careful about them too. So the next thing we're going to talk about is depression. That slide lists the symptoms of depression. You have to have 5 of those for at least 2 weeks to get the diagnosis of depression. Every now and again, people will have any of these symptoms intermittently. that are listed: difficulty sleeping, sleeping too much, tired, eating too much or too little, some somatic or physical complaints, can't concentrate. All those things culminate together for a longer period of time will interfere with the person's ability to function, and therefore they will qualify for treatment. Again, it's a continuum, and situations can make things worse temporarily, and then they can get better again. People might need treatment during situations like grief or trauma, but then maybe not anymore. Or people might need to be on medications like this all the time because they have a imbalance of the neurotransmitters inside their brain, all the way up into suicidality, delusions, hallucinations when you get closer to the end of the spectrum of the disease, where you might need to be on several medications or talk therapy or inpatient treatment, depending on how things are going. So with depression, the thought is that there's an imbalance of several neurotransmitters. On that slide, you can see dopamine, norepinephrine, and serotonin. And these neurotransmitters have different jobs. Dopamine is calming. We talked about, and relaxing. We talked about that when we talked about Parkinson's, but it also does increase your alertness. Norepinephrine is attention, concentration, memory, and serotonin is satisfaction, happiness, etc. So it's a balance of those that are crucial to not having those symptoms of depression. So the medication management is trying to increase the availability of these neurotransmitters, usually by preventing reuptake of the neurotransmitters for recycling, keeping them in the synapse so they can be used longer, or preventing their breakdown in the synapse so they can be used longer, so the person has more of their effects. There's nothing we can really do to increase the amount otherwise. All medications for depression have the ability in the short term, when the person first starts it, especially if the person is younger, to increase the possibility of suicide. My theory is that the neurotransmitter for concentration and alertness might increase faster than the one for satisfaction. So if you have a person that's very, very depressed, that lacks motivation and the ability to do anything, and then they get more motivation and ability to do something, but they're still sad, they might actually be able to act on that a little bit more. So everybody should be warned that in the very beginning, there might be more suicidal thoughts, and their family should be told that as well, so that we can be sure that they stay safe. So the three types of antidepressants are tricyclic antidepressants, Ssris, or selective serotonin reuptake inhibitors, and MAOIs, which inhibit the enzyme MAO that breaks down norepinephrine. So the tricyclics are named thus because they are supposed to affect all three of the neurotransmitters, dopamine, norepinephrine, and serotonin. So they have more side effects because they affect all of those, and which makes them sometimes difficult to tolerate. So you'll see the list of types of tricyclics, and you might recognize that some of them are used for other things. Amitriptyline is sometimes used for migraines or chronic pain or sleep. Imipramine is the one that is our prototype that we will talk about as the tricyclic. So it blocks reuptake of serotonin and norepinephrine. It can take a couple weeks to work, 2 weeks to work. It also has anticholinergic side effects. So that's dry mouth. What is particularly disturbing for patients is dry mouth and difficulty urinating and constipation. So sometimes people will stop taking it. It also can increase sweatiness for people. The other issue is that, as always, we have to worry about suicidal ideation, especially when we first start. It's going to take 2 weeks to work. It can cause cardiac dysrhythmias and cardiac problems, so it's contraindicated for that reason. And for that reason, can be easy to overdose on. So it actually can cause its own type of dysrhythmia. So the biggest thing to worry about with the tricyclics is heart issues. The biggest side effects are the anticholinergic, which is dry mouth, constipation, and difficulty urinating or urinary hesitancy. But we have to worry about the heart. Because there were side effects that made people not want to use the medication, and because we are at risk for cardiac dysrhythmias, and sometimes people use tricyclics to overdose, we came up with the new, or what is people are mostly used to seeing for depression, which are the SSRIs, serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. We only wanted to affect the serotonin within the central nervous system. There's serotonin in other places in your body, like your GI tract, which is sometimes why people have GI symptoms with these medicines. There are many types of SSRIs. Each of them are supposed to be more and more selective to the central nervous system itself to decrease the side effect profile. Our prototype is sertraline, which is Zoloft. So this is oral medication. So what are these, by the way, the tricyclics? These are also oral medications that can be PO pills or liquid. If it's a liquid, it should be mixed with another liquid like water, soda, or orange juice, something like that. This can take quite a bit of time to work, 2 to 4 weeks, because it has a very long half-life and it has protein binding, which makes it kind of unpredictable. So people need to be patient with these, especially. It's not going to help right away. They do have, sometimes people have issues with being too sleepy, and sometimes people have insomnia. So depending on which it is, should change when they take it. If they are very awake with them, they should take them in the morning. If they make them sleepy, they should take it at night. Some people have headaches. Some of the earlier SSRIs have more GI symptoms, although Zoloft does not have as much. All of the SSRIs have a potential for sexual dysfunction, either decreased libido, impotence, or both. People should be told about that. And again, increase in suicidal ideation in the beginning. There is a syndrome called serotonin syndrome. If someone has too much serotonin in their body, it can increase sweats, increase tremors, headache, and can lead to seizure activity, which is why it would be more dangerous. And so if you're taking medications that affect serotonin together, you have to worry about this. And so the medication that should come to your mind is one of those centrally acting pain medications, which is tramadol. Tramadol alters serotonin in order to change the perception of pain. But if the person is already on an SSRI, taking tramadol with that might increase the risk of serotonin syndrome, which they would notice as sweats, tremors, and potentially seizures. So that might not be a good medication combination. The last one, this isn't used as often because of its side effect and toxicity concerns, but you might hear it mentioned on commercials all the time. People are always saying, avoid with MAOIs, avoid with MAOIs. So what MAO is an enzyme that breaks down norepinephrine in the synapse. So if we inhibit that, we increase the amount of norepinephrine that's available. But we know that norepinephrine, in the central nervous system, it should help with wakefulness, attention, and mood. But in the periphery, that increases blood pressure. So the issue would be if you have cardiovascular issue, then your blood pressure should increase. So what you'll see on that slide, it says cannot be used in cardiovascular, cerebral vascular, and that's because it's an increase in blood pressure. hepatic and renal impairment because there's an increased risk of toxicity. And a pheochromocytoma is a tumor of the adrenal gland that increases the blood pressure. So if you have that, you don't want to take a medication that will increase the blood pressure. You can't use with tricyclic antidepressants or SSRIs because you have the potential to increase the temperature and cause seizures. The other issue is that you have to avoid caffeine and you have to avoid tyramine. And that is always a question that might be on ATI or might be on, certainly on my exam or NCLEX, is that tyramine foods are also broken down by MAO in the intestine. And if they're not, if that enzyme is inhibited, then the person could have a hypertensive crisis when they eat foods that have tyramine in them. And tyramine foods are things that people like, such as aged cheese, cured smoked meats, beer, wine, chocolate, soy, stuff like that. So they have to avoid those tyramine foods in order to avoid a hypertensive crisis. So that's very, very important. And there's multiple medication interactions with this, which is another reason why it's not used all the time. The prototype is phenelzine. So it's tricyclics, worry about the heart. And the prototype is imipramide. SSRIs, we don't want serotonin syndrome to occur. And our prototype is sertraline. And MAOIs, our prototype is phenelzine. We don't want a hypertensive crisis. Bipolar disorder means that the patient has periods of depression, excuse me, as well as periods of mania, which is elevated activity, irritability. There's some of the other characteristics of mania listed on that slide, which is grandiosity, thinking that you are better than anyone. If you're wondering why the table shakes sometimes, it's because my cat keeps jumping off the table. Decreased need for sleep, some increased goal-directed activity, excessive involvement in pleasurable activity. So people with mania feel really good, but they usually engage in very high-risk behaviors, and it's not a healthy. People lose their jobs, end up with drug and alcohol addiction, high-risk sexual behavior, spend all their money. Like, it's not a good, although they feel good, it's not good for them. So the first type of medication used to treat bipolar disorder was lithium, which does a good job in managing the mania. However, that's what makes it sometimes difficult for patients, is because they feel good when they're manic. If you take the manic away, then they might be more depressed. So lithium is actually a salt. Its range is 0.6 to 1.5 milliequivalents. It's a very tight range. And if it's if you become too high, then it's toxic, and the person could have circulatory collapse. So the blood pressure can be so low they could die. So there is also a relationship between the salt sodium and lithium. So if the sodium level gets too low, the lithium level will easily become toxic. So it's not that lithium causes hyponatremia. It is that if there is hyponatremia, lithium toxicity increases. So if the patient is sick and loses sodium for any reason, then they're at increased risk of toxicity. So we have a range here, which means that if the patient is below 0.6 milliequivalents per milliliter, then they're still going to have symptoms of mania. So all those mania symptoms that were listed, they're still going to have them. If they're within this range, then their mood should smooth out, and they shouldn't have all that manic stuff. If it's above, then they're toxic, and they have the possibility of that severe hypotension. So then, there's always questions about this. The patient's lithium level is 1.5. Do you give the medication? The answer is yes, because that's still within therapeutic range. So remember, it's a small range, so we got to use it. Because lithium does a good job managing mania, but not necessarily the depressive aspects. It's not necessarily what's used for bipolar anymore. Usually the atypical antipsychotics or anti-seizure meds are actually better at managing bipolar and mood stabilization. The next disorder is attention deficit hyperactivity disorder. In order to be diagnosed with ADHD, it should be diagnosed by a neuropsychiatrist, not a family doctor. And it is those characteristics that are listed: distractible, can't focus, can't remember, inability to sit still, impulsive, sleep disturbance. But again, there's a continuum, and some of those symptoms are normal for childhood or normal when people are overwhelmed and get kind of bored. It's when those symptoms interfere with your ability to function. And for children, that can decrease the ability to academically achieve, and they can be more disruptive in class. And so if that's the case, then sometimes medications can work. Although there's a lot of people that think that these medications are overprescribed for some childhood behaviors. And there's a lot of people that question the diagnosis of adult onset ADHD. It's possible that adults that are finally given medications for ADHD were undiagnosed as children. A lot of times children will grow out of this behavior with time as well. So the treatment of choice are actually CNS stimulants, which seems weird, but because people who have ADHD seem hyper. But the stimulant helps to focus the attention, which is the problem. And so the prototype medication is methylphenidate, which is Ritalin, although a lot of people are prescribed Adderall instead, especially for adult onset. So methylphenidate, or Ritalin, heightens alertness. They're usually sustained release, so you shouldn't break or crush them. It is a controlled substance. There is a risk of dependence, and there is abuse of these medications. Sometimes people use them just because they have to study or share them. So they are a controlled substance and are subject to those rules for prescribing. For children especially, the biggest issue, which isn't listed on that slide, is weight loss. It can really decrease their appetite, and therefore they lose weight. So they need to have their weights checked, and they should be given drug holidays for that reason, because we don't want to inhibit their growth. So it should be really used, if the problem is school achievement, then it should be used during school. It shouldn't be used on the weekends or when they're not in school. Then it gives them a break so that they can still gain weight and meet their growth requirements. Other issues are nervousness, insomnia, and high blood pressure, as well as liver toxicity. Okay, and then the last issue we're going to talk about is psychosis. So I did mention that, especially with anxiety and depression, the end of the spectrum of those symptoms is psychosis. But we always typically think of psychosis as also being a part of schizophrenia. So it's either the end of the continuum of depression and anxiety or part of schizophrenia. So people with psychosis have delusions, ideas, beliefs that aren't in reality, hallucinations, seeing, hearing things, sensory experiences that aren't in reality. Paranoia, extremely suspicious, and distorted perceptions of stimuli. So these are considered a break from reality, essentially. Schizophrenia has all of those behaviors: the hallucinations, delusions, paranoia. Those psychotic symptoms are described as positive, which is weird for people sometimes because they're like, well, positive symptoms, that means good. No, it means in addition to regular behavior. So people with schizophrenia have those break from reality symptoms, those positive symptoms, in addition to negative symptoms or symptoms that subtract from normal behavior, such as detachment, deterioration of job and school performance, and withdrawal from social isolation. They have both. So the medications do a better job in treating the positive symptoms, or those hallucinations, delusions, paranoia, suspicious, weird behaviors. But they don't always do as much for the social isolation, withdrawal, and deterioration of the person. And so that's why there's compliance issues. Because we get rid of positive symptoms, but we're left with the negative symptoms. So phenothiazines are the first antipsychotic medications, and your prototype is chlorpromazine, which actually works on the dopamine receptor, and it does get rid of mania and positive symptoms, but can leave the patient with the negative symptoms, and so there's the compliance issue. Other side effects: dizziness, drowsiness, orthostatic hypotension, and then we have to worry about tardive dyskinesia and neuroleptic malignant syndrome. So let me just show you. This is the cat here that keeps jumping on and off the table. So say hi. You're the one that keeps shaking everything. Okay, stop it. Tardive dyskinesia is what we talked about with the Parkinson's meds, that excessive eye blinking, lip smacking, sticking out the tongue, stuff like that. Otherwise, extrapyramidal symptoms are things like Parkinson's, like shaking, rigidity, stuff like that. So obviously people wouldn't like those types of symptoms. Neuroleptic malignant syndrome is fever and hypertension, which could be fatal to the patient. And so that often is why people who are on these medications need to have air conditioning. That can be a problem in the summertime with people who don't have the resources to pay their electric bill and lose air conditioning. People on psych meds are very prone to hyperthermia and problems related to heat exposure because it can trigger this symptom. So those are the adverse effects. So what can we do? Well, then there was the non-phenothiazines that were developed, which is haloperidol or Haldol. There's less sedation, less hypotension. This neuroleptic malignant syndrome is rarer, but they could still have these extrapyramidal symptoms, so a little better. Then we came up with, let's try to get rid of that too, the atypicals. So Zyprexa or Alazapine was probably one of the first ones. Risperidone is one that's commonly used now. Some of these atypicals can be used for depression and bipolar disorder, so you might see them for something else, but they do work for schizophrenia. And the one that we talk about is risperidone, which also works on the dopamine receptors, and it's supposed to reduce both positive and negative behaviors. So that's why it's a really good medication. It's not just the positive ones. We still have to worry about low blood pressure and EPS symptoms, but we really don't have to worry about the neuroleptic malignant syndrome. The issue with these medicines is weight. So that'll always be a question on the exam. People can start these medications and gain like 60 pounds in a month. And if they're diabetic, it's a big problem because it brings their blood sugar up. So they really need to have a good diet.